Cambridge, Massachusetts. This year's presentations will underscore Takeda's unwavering pursuit to advance hematologic cancer therapy and continue building upon research in difficult-to-treat solid tumors. At ASCO and NATO we will present data, real-world findings and trial updates on our pipeline assets as well as our marketed therapies, said Christophe Bianchi, MD, President, Takeda Oncology. At ASCO, we will present updated Phase 2 ALTA trial results examining long-term efficacy and safety of ALU-NBRIG in patients with ALK non-small cell lung cancer who are refractory to crizotinib. Notably, at ASCO we will present data on pre-specified subgroups from the Echelon-1 Phase 3 trial evaluating a combination with ADC-TRIS as a frontline treatment for patients with Hodgkin lymphoma. Takeda's research continues to push innovation in oncology to advance needed treatments and illustrates the company's vision to improve the lives of cancer patients. At this year's ASCO meeting, updated Phase 2 ALTA, ALK in lung cancer trial of AP26113 trial results examining long-term efficacy and safety of ALU-NBRIG, brigatinib, and a crizotinib refractory anaplastic lymphoma kinase-positive ALK non-small cell lung cancer NSCLC population will be presented. During the poster discussion presentations, TAK 788, a small molecule tyrosine kinase inhibitor targeting the epidermal growth factor receptor (EGFR) and human epidermal growth factor receptor 2 (HER2) mutations, including exon 20 insertions, will report on the safety, pharmacokinetics and preliminary anti-tumor activity of this molecule in NSCLC patients. In addition, results from a first-in-human Phase 1 study of TAK 931, a small molecule inhibitor of the CDC7 kinase activity, in patients with advanced solid tumors will be shared during the oral presentations. The trial, which investigates the effect of TAK 931 in up to 100 participants with solid tumors, examines the safety, tolerability and pharmacokinetics of the oral medication to determine the maximum tolerated dose. The company also continues to deepen its scientific body of knowledge in hematologic cancers. At ASCO, the company will present 8 trials in progress poster on the ongoing randomized global Phase 3 trial, PANTHER, investigational intravenous pevonedistat plus azacitidine versus single-agent azacitidine as first-line treatment for patients with higher-risk myelodysplastic syndrome, MDS, chronic myelomonocytic leukemia or low-blast acute myelogenous leukemia, AML. Furthermore, at this year's ASCO meeting, data on the efficacy and safety of a combination with ADC-TRIS brentuximab vedotin in pre-specified subgroups with more advanced disease from the Echelon-1 trial will be presented. Data demonstrate greater benefit across these subgroups compared to the intent-to-treat population regardless of PET2 status based on the primary endpoint of modified progression-free survival. In addition, encore data from the Phase 3 Echelon-1 clinical trial evaluating ADC-TRIS as part of a frontline combination chemotherapy regimen in previously untreated advanced-stage Hodgkin lymphoma will be featured. The data was previously presented in the plenary session at the 59th American Society of Hematology (ASH) annual meeting in December 2017. Finally, a study of TAK 659, a reversible dual inhibitor of spleen tyrosine kinase (SYK) and FMS-like tyrosine kinase 3 (FLT3), in combination with standard of care treatments will present preliminary safety and efficacy data in diffuse large B-cell lymphoma models. Safety, efficacy and real-world use findings from Takeda Oncology-sponsored trials examining a variety of blood cancers, including lymphoma, multiple myeloma and MDS, will be featured at ASCO and/or ASCO. The 6 Takeda Oncology-sponsored abstracts accepted for presentation during ASCO 2018 and 8 abstracts at ASCO 2018 include, ASCO Annual Meeting 2018 Note, all times listed are in Central Daylight Time. ADCETRIS brentuximab vedotin, ALUNBRIG, brigatinib, pipeline first-in-human phase 1 study of TOP 931, an oral cell division cycle 7, CDC7, inhibitor in patients PTS with advanced solid tumors. Abstract 2506. Oral presentation. Friday, June 1, 4:09 to 4:21 p.m., S406. First report of safety, PK and preliminary anti-tumor activity of the oral EGFR, HER2 exon 20 inhibitor TOC 788, AP32788 in non-small cell lung cancer, NSCLC. Abstract 9015. Sunday, June 3, 11:30 a.m. to 12:45 p.m., Hall A. Phase 3 study of first-line, pevonedistat PEV, azacitidine, AZA, versus single-agent AZA in patients with higher-risk myelodysplastic syndromes, HRMDS, chronic myelomonocytic leukemia, CMML, or low-blast acute myelogenous leukemia, AML. Abstract TPS 7077. Monday, June 4, 8 o'clock to 11 a.m., Hall A. AHA 23rd Congress Note, all times listed are in Central European Time. ADCETRIS brentuximab vedotin plus chemotherapy in high-risk advanced-stage classical Hodgkin lymphoma, CHL, patients, results of pre-specified subgroup analysis from the Echelon-1 study. Abstract S112. Oral presentation. Friday, June 15, 12 o'clock to 12:15 p.m., Room A2. Brentuximab vedotin with chemotherapy for Stage 3 or IV Hodgkin lymphoma, impact of Cycle 2 PET, modified progression-free survival. Abstract PS1172. Saturday, June 16, 5:30 to 7 p.m., Poster area. Frontline brentuximab vedotin plus chemotherapy exhibits superior modified progression-free survival versus chemotherapy alone in patients with Stage 3 or IV Hodgkin lymphoma, Phase 3 Echelon-1 study. Abstract PS1182. Saturday, June 16, 5:30 to 7 p.m., Poster area. Brentuximab vedotin in relapsed, refractory systemic anaplastic large cell lymphoma, a cost-effectiveness analysis. Abstract PF 684. Friday, June 15, 5:30 to 7 p.m., Poster area. NINLARO, ixazimib, a global treatment standard in multiple myeloma, remains elusive despite advances in care over 15 years. First results from INSIGHT, the largest global prospective observational study. Abstract PS 1300. Saturday, June 16, 5:30 to 7 p.m., Poster area. Randomized clinical trial, RCT, representativeness. Abstract PS 1336. Saturday, June 16, 5:30 to 7 p.m., Poster area. Pipeline. For more information, please see ASCO, https://am.asco.org/program/ and AHA, http://aha-2018.org/online programs. About ADCETRIS. ADCETRIS is an ADC comprising an anti-CD30 monoclonal antibody attached by a protease cleavable linker to a microtubule disrupting agent, monomethyl auristatin E, MMAE, utilizing Seattle Genetics proprietary technology. The ADC employs a linker system that is designed to be stable in the bloodstream but to release MMAE upon internalization into CD30-positive tumor cells. ADCETRIS injection for intravenous infusion has received FDA regular approval for 5 indications in adult patients with 1. Previously untreated stage 3 or IV classical Hodgkin lymphoma (CHL) in combination with chemotherapy, 2. CHL at high risk of relapse or progression as post-autologous hematopoietic stem cell transplantation, auto-HSCT consolidation, 3. CHL after failure of auto-HSCT or failure of at least 2 prior multi-agent chemotherapy regimens in patients who are not auto-HSCT candidates, 4. SALCL after failure of at least 1 prior multi-agent chemotherapy regimen, and 5. Primary cutaneous anaplastic large cell lymphoma PCALCL, or CD30 expressing mycosis fungoides MF who have received prior systemic therapy. Health Canada granted ADCETRIS approval with conditions for relapse or refractory Hodgkin lymphoma and SALCL in 2013, and non-conditional approval for post-autologous stem cell transplant (ASCT) consolidation treatment of Hodgkin lymphoma patients at increased risk of relapse or progression. ADCETRIS received conditional marketing authorization from the European Commission in October 2012. The approved indications in Europe are, 1. For the treatment of adult patients with relapse or refractory CD30-positive Hodgkin lymphoma following ASCT, or following at least 2 prior therapies when ASCT or multi-agent chemotherapy is not a treatment option. 2. The treatment of adult patients with relapse or refractory SALCL. 3. For the treatment of adult patients with CD30-positive Hodgkin lymphoma at increased risk of relapse or progression following ASCT, and 4. For the treatment of adult patients with CD30-positive cutaneous T-cell lymphoma (CTCL) after at least 1 prior systemic therapy. ADCETRIS has received marketing authorization by regulatory authorities in more than 70 countries for relapse or refractory Hodgkin lymphoma and SALCL. See important safety information below. ADCETRIS is being evaluated broadly in more than 70 clinical trials, including a Phase 3 study in frontline Hodgkin lymphoma Echelon 1, and another Phase 3 study in frontline CD30-positive peripheral T-cell lymphomas Echelon 2, as well as trials in many additional types of CD30-positive malignancies. Seattle Genetics and Takeda are jointly developing ADCETRIS. Under the terms of the collaboration agreement, Seattle Genetics has U.S. and Canadian commercialization rights and Takeda has rights to commercialize ADCETRIS in the rest of the world. Seattle Genetics and Takeda are funding joint development costs for ADCETRIS on a 50-50 basis, except in Japan where Takeda is solely responsible for development costs. ADCETRIS brentuximab vedotin. Important safety information. European Union. Please refer to Summary of Product Characteristics (SMPC) before prescribing. CONTRAINDICATIONS ADCETRIS is contraindicated for patients with hypersensitivity to brentuximab vedotin and its excipients. In addition, combined use of ADCETRIS with bleomycin causes pulmonary toxicity. Special warnings. PML has been reported in patients who received ADCETRIS after receiving multiple prior chemotherapy regimens. PML is a rare demyelinating disease of the central nervous system that results from reactivation of latent JCV and is often fatal. Closely monitor patients for new or worsening neurological, cognitive, or behavioral signs or symptoms, which may be suggestive of PML. Suggested evaluation of PML includes neurology consultation, gadolinium enhanced magnetic resonance imaging of the brain, and cerebrospinal fluid analysis for JCV DNA by polymerase chain reaction or a brain biopsy with evidence of JCV. A negative JCV PCR does not exclude PML. Additional follow-up and evaluation may be warranted if no alternative diagnosis can be established. Hold dosing for any suspected case of PML and permanently discontinue ADCETRIS if a diagnosis of PML is confirmed. Be alert to PML symptoms that the patient may not notice, e.g., cognitive, neurological, or psychiatric symptoms. Pancreatitis. Acute pancreatitis has been observed in patients treated with ADCETRIS. Fatal outcomes have been reported. Closely monitor patients for new or worsening abdominal pain, which may be suggestive of acute pancreatitis. Patient evaluation may include physical examinations, laboratory evaluation for serum amylase and serum lipase, and abdominal imaging, such as ultrasound and other appropriate diagnostic measures. Hold ADCETRIS for any suspected case of acute pancreatitis. ADCETRIS should be discontinued if a diagnosis of acute pancreatitis is confirmed. Pulmonary toxicity. Cases of pulmonary toxicity, some with fatal outcomes, including pneumonitis, interstitial lung disease, and acute respiratory distress syndrome, ARDS, have been reported in patients receiving ADCETRIS. Although a causal association with ADCETRIS has not been established, the risk of pulmonary toxicity cannot be ruled out. Promptly evaluate and treat new or worsening pulmonary symptoms appropriately. Consider holding dosing during evaluation and until symptomatic improvement. Serious infections and opportunistic infections. Serious infections such as pneumonia, staphylococcal bacteremia, sepsis, septic shock, including fatal outcomes, and herpes zoster, and opportunistic infections such as pneumocystis jirovecii pneumonia and oral candidiasis have been reported in patients treated with ADCETRIS. Carefully monitor patients during treatment for emergence of possible serious and opportunistic infections. Infusion-related reactions, IRR, immediate and delayed IRR, as well as anaphylaxis, have occurred with ADCETRIS. Carefully monitor patients during and after an infusion. If anaphylaxis occurs, immediately and permanently discontinue administration of ADCETRIS. Appropriate medical therapy should be administered. If an IRR occurs, interrupt the infusion and institute appropriate medical management. The infusion may be restarted at a slower rate after symptom resolution. Patients who have experienced a prior IRR should be pre-medicated for subsequent infusions. IRRs are more frequent and more severe in patients with antibodies to ADCETRIS. Tumor lysis syndrome, TLS, TLEs has been reported with ADCETRIS. Patients with rapidly proliferating tumor and high tumor burden are at risk of TLS. Monitor these patients closely and managed according to best medical practice. Peripheral neuropathy, PN, ADCETRIS treatment may cause PN, both sensory and motor. ADCETRIS-induced PN is typically cumulative and reversible in most cases. Monitor patients for symptoms of PN, such as hypoesthesia, hyperesthesia, paresthesia, discomfort, a burning sensation, neuropathic pain, or weakness. Patients experiencing new or worsening PN may require a delay in a dose reduction or discontinuation of ADCETRIS. Hematological toxicities, grade 3 or grade 4 anemia, thrombocytopenia, and prolonged, equal to or greater than 1 week, grade 3 or grade 4 neutropenia can occur with ADCETRIS. Monitor complete blood counts prior to administration of each dose. Febrile neutropenia. Febrile neutropenia has been reported. Closely monitor patients for fever and manage according to best medical practice if febrile neutropenia develops. Stevens-Johnson syndrome, SJS and toxic epidermal necrolysis, TEN, have been reported with ADCETRIS. fatal outcomes have been reported. Discontinue treatment with ADCETRIS if SJS or 10 occurs and administer appropriate medical therapy. Gastrointestinal key complications, some with fatal outcomes, including intestinal obstruction, ileus, enterocolitis, neutropenic colitis, erosion, ulcer, perforation and hemorrhage, have been reported. Promptly evaluate and treat patients if new or worsening GI symptoms occur. Hepatotoxicity, elevations in alanine aminotransferase ALT and aspartate aminotransferase AST have been reported. Serious cases of hepatotoxicity, including fatal outcomes, have also occurred. Test liver function prior to treatment initiation and routinely monitor patients receiving ADCETRIS for liver elevations. Patients experiencing hepatotoxicity may require a delay, dose modification, or discontinuation of ADCETRIS. Hyperglycemia has been reported during trials in patients with an elevated body mass index (BMI), with or without a history of diabetes mellitus. Closely monitor serum glucose for patients who experiences an event of hyperglycemia. Administer anti-diabetic treatment as appropriate. Renal and hepatic impairment. There is limited experience in patients with renal and hepatic impairment. Available data indicate that MMAE clearance might be affected by severe renal impairment, hepatic impairment, and by low serum albumin concentrations. CD30-CTCL. The size of the treatment effect in CD30-CTCL subtypes other than mycosis fungoides, MF, and primary cutaneous anaplastic large cell lymphoma, PCALCL, is not clear due to lack of high-level evidence. In two single-arm phase 2 studies of ADCETRIS, disease activity has been shown in the subtypes Sézary syndrome, SS, lymphomatoid papulosis, LYP, and mixed CTCL histology. These data suggest that efficacy and safety can be extrapolated to other CTCL CD30 subtypes. Carefully consider the benefit-risk for patient and use caution in other CD30-CTCL patient types. Sodium content in excipients. ADCETRIS contains a maximum of 2.1 mmol, or 47 mg of sodium per dose. Take this into consideration for patients on a controlled sodium diet. Interactions. Patients who are receiving a strong CYP3A4 and PGP inhibitor, concomitantly with ADCETRIS, may have an increased risk of neutropenia and should be closely monitored. Co-administration of ADCETRIS with a CYP3A4 inducer did not alter the plasma exposure of ADCETRIS, but it appeared to reduce plasma concentrations of MMAE metabolites that could be assayed. ADCETRIS is not expected to alter the exposure to drugs that are metabolized by CYP3A4 enzymes. Pregnancy. Advise women of childbearing potential to use two methods of effective contraception during treatment with ADCETRIS and until 6 months after treatment. There are no data from the use of ADCETRIS in pregnant women, although studies in animals have shown reproductive toxicity. Do not use ADCETRIS during pregnancy unless the benefit to the mother outweighs the potential risks to the fetus. Lactation, breastfeeding. There are no data as to whether ADCETRIS or its metabolites are excreted in human milk, therefore a risk to the newborn infant cannot be excluded. With the potential risk, a decision should be made whether to discontinue breastfeeding or abstain from therapy with ADCETRIS. Fertility. In non-clinical studies, ADCETRIS treatment has resulted in testicular toxicity, and may alter male fertility. Advise men being treated with ADCETRIS not to father a child during treatment and for up to 6 months following the last dose. Effects on ability to drive and use machines. ADCETRIS may have a minor influence on the ability to drive and use machines. Undesirable effects. The most frequent adverse reactions, 10%, were infections, peripheral sensory neuropathy, nausea, fatigue, diarrhea, pyrexia, upper respiratory tract infection, neutropenia, rash, cough, vomiting, arthralgia, peripheral motor neuropathy, infusion-related reactions, pruritus, constipation, dyspnea, weight decreased, myalgia and abdominal pain. Serious adverse drug reactions were pneumonia, acute respiratory distress syndrome, headache, neutropenia, thrombocytopenia, constipation, diarrhea, vomiting, nausea, pyrexia, peripheral motor neuropathy, peripheral sensory neuropathy, hyperglycemia, demyelinating polyneuropathy, tumor lysis syndrome, and Stevens-Johnson syndrome. Serious adverse drug reactions occurred in 12% of patients. The frequency of unique serious adverse drug reactions was 1%. ADCETRIS brentuximab vedotin, U.S. Important safety information box. Warning: progressive multifocal leukoencephalopathy (PML), JC virus infection resulting in PML and death can occur in ADCETRIS treated patients. Contraindication: ADCETRIS concomitant with bleomycin due to pulmonary toxicity, e.g., interstitial infiltration and/or inflammation. Warnings and precautions: peripheral neuropathy, PN. ADCETRIS causes PN that is predominantly sensory. Cases of motor PN have also been reported. ADCETRIS-induced PN is cumulative. Monitor for symptoms such as hypoesthesia, hyperesthesia, paresthesia, discomfort, a burning sensation, neuropathic pain, or weakness. Institute dose modifications accordingly. Anaphylaxis and infusion reactions. Infusion-related reactions, IRR, including anaphylaxis, have occurred with ADCETRIS. Monitor patients during infusion. If an IRR occurs, interrupt the infusion and institute appropriate medical management. If anaphylaxis occurs, immediately and permanently discontinue the infusion and administer appropriate medical therapy. Premedicate patients with a prior IRR before subsequent infusions. Premedication may include acetaminophen, an antihistamine, and a corticosteroid. Hematologic toxicities, prolonged 1-week, severe neutropenia and grade 3 or 4 thrombocytopenia or anemia can occur with ADCETRIS. Febrile neutropenia has been reported with ADCETRIS. Monitor complete blood counts prior to each ADCETRIS dose. Consider more frequent monitoring for patients with grade 3 or 4 neutropenia. Monitor patients for fever. If grade 3 or 4 neutropenia develops, consider dose delays, reductions, discontinuation, or GCSF prophylaxis with subsequent doses. Serious infections and opportunistic infections. Infections such as pneumonia, bacteremia, and sepsis or septic shock, including fatal outcomes, have been reported in ADCETRIS-treated patients. Closely monitor patients during treatment for bacterial, fungal, or viral infections. Tumor lysis syndrome. Closely monitor patients with rapidly proliferating tumor and high tumor burden. Increased toxicity. In the presence of severe renal impairment, the frequency of grade 3 adverse reactions and deaths was greater in patients with severe renal impairment compared to patients with normal renal function. Avoid use in patients with severe renal impairment. Increased toxicity. In the presence of moderate or severe hepatic impairment, the frequency of grade 3 adverse reactions and deaths was greater in patients with moderate or severe hepatic impairment compared to patients with normal hepatic function. Avoid use in patients with moderate or severe hepatic impairment. Hepatotoxicity. Serious cases, including fatal outcomes, have occurred in ADCETRIS-treated patients. Cases were consistent with hepatocellular injury, including elevations of transaminases and/or bilirubin, and occurred after the first ADCETRIS dose or rechallenge. Pre-existing liver disease, elevated baseline liver enzymes, and concomitant